So anytime we have fracture, a curved bone like that, like a mandible, um, the anterior, that's what we refer to as anterior pelvic bones. Anytime we have fracture in one place, we're going to have fracture in multiple places. Okay. So we're going to have to do something to be able to visualize those. We'll talk about those hopefully later today. And if not, then I'll get a recording out. So looks like this. That's your ischial ramus. Ischial tuberosity is what you sit on, inferior ramus. Then you've got the pubic bone starts here. This entire region is what we refer to as obturator foramen. Acetabulum is that cup right there. With acetabulum, again, we've got all three bones converging to create that. That's your ilium or iliac bone, iliac crest. You've got the ASIS. We've got the posterior PSIS. It just doesn't come off the tongue because we just almost never talk about it. So ASIS, and then we've got the the iliac crest up top. So innominate bone, that entire thing there. So that's from a side view. That's your acetabulum again, obturator foramen, ischial tuberosity, ischial ramus, obturator foramen, and then where the two come together is, of course, what we refer to as the symphysis pubis. All right, so the femur, we've talked about this. We've got in the femur, we've got the longest, strongest bone in the body. And we've got the head, we've got greater trochanter, intertrochanteric line. That would be your surgical neck, femoral neck, whichever one you want to call it, lesser trochanter, and then we've got the body that eventually becomes the distal portion. You do have joints between your sacrum and your iliac bone rolling back up here. So your sacrum joins right up in here, and that joint space in between the two is a fibrous joint space. It doesn't move much, if at all, but that is what we call our sacroiliac joint. And you can develop some arthritis in there that can be painful as well. So we can do SI joints. Again, full disclosure, I've never done them, but we can do some. So the SI joints don't move much. The hip joint, what we refer to as the hip joint, does move a lot. It's a ball and socket joint, so it's a synovial joint. A lot of movement there. And the symphysis pubis is cartilaginous, and we get slight movement there, especially during childbirth. You release hormones that make that spread just a little bit to make a little bit more room for in the birth canal for the baby to come through. So in our fractures, whenever we have fractures of our pelvic bones, in a lot of cases, what you'll see is marked increase in distance between pubic bones. So you got the fractures in either the iliac bones or in the anterior pelvic bones, and what you see sometimes, especially in crush injuries, very common if somebody's riding a horse and the horse rolls over on them. That pelvis is just going to kind of flatten out, and your symphysis pubis there's going to be 2 or 3 inch gap in your symphysis pubis. So there are differences in the male and female, the appearance of the male and female pelvis. So in the males, they're going to be heavier and they're going to be more narrow. The birth canal is obviously not present. And the angle at the symphysis pubis is very acute. So it's at about a 90-degree angle. It's, again, it's hard. Sometimes I have to kind of tilt my head to kind of grasp, and it's probably, I don't know, it may be closer to a 45-degree angle. But, if we're at a 90-degree angle here, sometimes I kind of have to tilt my head to make it fit. But it's going to be a very pointed, sharp appearance, as opposed to the female pelvis going to be more flattened out. Okay, that's anterior pelvic bones. We'll take a look at that here in a minute. The female pelvis is much wider, shallower, and it's got a much larger, hole in the middle for the birth canal. And the angle of the symphysis pubis is going to be very obtuse. Okay, so now what I want you to do is I want you to turn. We got to run through this, but the localization of the hip, but I'm going to tell you the easy way to position for hip and proximal pelvis or proximal femur here in a bit. You find it. Okay, so if you look on page 389 and you read through all those localization anatomic structures and all that. So the diagram, especially figure 8-8.12, is telling you how to find the different structures in the hip and the proximal portion of the femur. Okay, so what it says to do is to imagine a line that goes from the symphysis pubis up to the ASIS. So the only way you're going to find the symphysis pubis is by palpating. We went over that in abdomen. Really don't recommend you do that, right? But you need to file this away. This is, how the registry is going to ask you the question. So what that diagram is showing is how to find the head and the neck of the femur. Okay, and it says if you were to take a line that goes from the symphysis pubis up to the ASIS and cut that line in half, go halfway down that line, and then you would go, what are the distances? 1.5 inches below that line, you would find the head of the femur. 2.5 inches, you'd find the neck of the femur. Okay. The question is probably going to come at you like something like this. How do you find the head of the femur? Let's say. So draw a line from the symphysis pubis to the ASIS, bisect that line, which means cut it in half, then go down that line 2.5 inches or 1.5 inches for the head of the femur, 2.5 inches for the neck of the femur. You might also say, draw a line that bisects the line, right? And then the rest of that stuff. So that's registry testable localization of the hip. The easiest way to take an AP of the hip or the femur, let me get to it, is here. All right. So that's the diagram. So you got a line, you bisect that line 1.5 inches down the second line, you got the head of the femur, 2.5 inches, you got the head. But okay, this is the shaft of the femur. All right. So if we're looking for the hip or the proximal portion of the femur, we want the long axis of our column motion pretty much running parallel to this. The reason I say that is because you want that covering your photocell. It's the hardest part of the anatomy. It's the thickest part of the anatomy. You want that directly over the photocell so that you get the right density, you get the right exposure to the image receptor. Okay, we're going to cover that more in physics and imaging, but that's what you want is you want that directly in the center of your image. Okay. So open up the collimation enough to include that, but you want to put that directly in the center of the image. Now, is there in this diagram a palpable anatomy that would be, I'm going to give you a hint, directly over the top of that you could use to line that line up? That's right. So if on your AP of the hip, if you were to put the top of your collimated field at the ASIS, your collimated field is going to be about a 10 by 12. Put the top of the collimated field at the ASIS and open up to 10 by 12. You're going to hit it every single time. Every single time. Okay, I mean, you could do this if you want to. Guys, you might be in for a human resources department talking to somebody about touching somebody inappropriately, even though you might not have. And I've had female techs that did, they were symphysis pubis palpators who had their patients move their anatomy after they figured out exactly what they were going to be feeling of. Okay, so unless you want that to happen to you, I don't recommend palpating the symphysis pubis for anybody. So top of the image receptor, or if you're shooting for a femur, top of the image receptor at the ASIS, possibly slightly above it, just to account for divergence of the central ray. But use the ASIS the femur should be straight down from the ASIS. You're going to hit it every time. And you're not going to have to do all this. You got to remember this for the registry. You got to remember this for the test. But again, that's just my advice. Don't go palpating anybody's symphysis pubis. Okay? All right. So patient preparation, just like everything else, you want to make sure that anything that the patient has that can come off the patient needs to come off the patient. So if you got a patient with some, the jeans on with zippers and stuff like that, if at all possible, it needs to come off the patient, right? Sometimes your elastic can be thick enough that it can cast in the fact. Put a gown on the patient, but keep them covered. Whenever we do that cross table lateral, make sure that the patient stays covered throughout all of the exams. All right. So AP pelvis, what we're going to do with AP pelvis is put the top of the image receptor just above the top of the crest. All right. Well, the easiest exams you're going to do. Top of the image receptor, top of the crest. And providing the patient doesn't have a fracture, internally rotate the toes 15, 20 degrees. So if the patient says, I can't, internally rotate my toes, well, then take them at their word. If they've got those telltale signs, some of your hospitals will use an AP of the pelvis and use that instead of an AP of the hip. So, if they've got those telltale signs, the patient has a broken hip, then don't try to internally rotate that particular toe. Internally rotate the other one. But if it's an ambulatory patient and they can get up on the table, they came walking in, they can get up on the table, internally rotate the toes. You're going to forget to do this at least once. And both of your, because the patient's going to be relaxed, they're going to externally rotate the toes, and both of your hips are going to look like this. Okay. And somebody's going to say, you forgot to internally rotate the toes. And you're going to say, no, I didn't, because you're going to think you did. But that's what it's going to look like, right? You internally rotate the toes, it's going to look like that. It's obvious whenever the toes are not internally rotated. So make sure you internally rotate the toes, again, 15, 20 degrees. Have the patient hold their breath. Most of your lower extremities, you don't have to have the patient hold their breath, but I would recommend it in this one just to kind of keep the, bowel movement down if at all possible. Okay, should look like that. So this is a female pelvis. You see how broad it is? Male pelvis is going to come off. Anterior pelvic bone is going to be more like this angulation here. Okay, this is going to be much smaller than the male pelvis as well. So, whenever they find remains, skeletal remains, that's how we, identify male from female. That's one of them. All right. So you got your AP, and we can do a bilateral lateral hip. Okay, some people will refer to it as bilateral frog leg. And so what I want you to do first is it's kind of rare that they put this in the book in this order, but on page 400, you see the positioning for this, but it comes with a 40-degree cephalic angulation. Okay, that's the original Cleaves method. That's not what we do. Okay, so flip back one page, page 398. That's your bilateral frog leg. It's pretty simple too. You might center a little bit lower, but what you're going to do is have the patient bend their knees up to about 90 degrees, put the sole of their feet together, and then have them externally rotate and abduct their femur so that it puts it as lateral as possible. Now, some of your patients aren't going to be able to put their knee all the way down. Encourage them to put them as low as they can, but some of your patients are just not going to be able to lay their feet all the way or their knees all the way down like that. Put the sole of the feet together, because if you don't, they're going to slide under each other and you're just not going to get the result that you're looking for. You might center a little bit lower instead of going 1.5 inches above the top of the crest. What we're looking for now is a little bit more of the femur. We already got good pelvis. We're looking for a little bit more of the femur, so you might center just a little bit lower at the iliac crest, maybe an inch and a half below the forehead. And you should get what you're looking at on the opposite page, 8.23. 8.23 is this image right here. And that is your, kind of your stereotypical appearance of a hip nail. Okay. So we'll describe that here in a minute. And I think I told you the process of this one before. Okay. So we talked about the Denelius Miller. So essential projections of the hip, we got AP and lateral. Lateral is basically the same as the frog leg that we just looked at, Clement's method, but it's going to be unilateral. And what you can do, you notice the difference between 8.2 and 8.21. The knee's a whole lot closer to the image receptor, 8.21, right? So what you might do is, if you're doing a unilateral, that's what we're going to refer to as a Lowenstein-Hickey method. It's really just the unilateral modified cleaves, the same thing, is to oblique the patient just ever so slightly, just to get it, down a little bit lower. You don't have the foreshortening of the femur like what you would have in 8.2. Okay. So AP of the hip. Again, what you're going to do is you're going to put the top of the image receptor or top of the collimated field really at the ASIS. And then you're going to run that longitudinal line of collimation straight down from the ASIS. I mean, we could have centered this up better than this. Run that longitudinal line of collimation straight down from the ASIS, and it should follow the finger. All right, top of a 10 by 12 collimated field at the ASIS. And look at your collimator housing and adjust it to 10 by 12, put the top of it at the ASIS, and run that line of collimation straight down to the hip. You collimate in if you need to, if the patient, is smaller. But it'll work on every single patient you use, that you have. Okay. So Lowenstein-Hickey method is, again, just unilateral frog leg. And you can use same localization unless you oblique the patient. If you oblique the patient, you may need to make a little bit of an adjustment and, move them, the tabletop, to where you would include a little bit more of the femur. But it's going to be subtle. Also, though, in your frog leg, I'm just going to refer to it as frog leg because that's what we refer to it as. In your frog leg, you might not be centered over that radiation detector. Okay, so what you might do is, for the AP, if you position properly and you got a good exposure, your index number looks good. For the AP, you might turn the phototimers off and use the technique that the AP shot with. Pay attention to what it shoots with. You make your exposure and it gives you a readout, which mass was. You might want to turn those off and set your technique based on what the AP used. Does that kind of make sense? Pay attention to what it's shot with and just set your mass based on that. Because if the AP gave you a good exposure, then the frog leg should be shot with exactly the same technique. Okay. And if you missed it, then you might just shoot with a higher I gotta explain the plus ones, but with a look next time you're in clinicals, look on your control panel. You should have these settings that just have plus and minus on them. Okay. And what that does is that when you make an exposure, if you hit plus, it just gives you more mass. I'll explain it a little bit deeper in physics, but if you hit +1, it gives you a little bit more mass. If you hit it with +2, it gives you a little bit more mass than +1, and so on. If you hit it with -1, it goes in the opposite direction. Okay. So if you can't position directly over the photocell, you hit it with +1, +2, +3, something like that. It kind of compensates for your positioning error. Okay. Okay. So the Nellius Miller we already talked about, um, and for the most part, this here is just kind of telling you that if the patient doesn't have a broken hip, then you can internally rotate the toes. You should internally rotate the toes so that the leg is in the same position for the surgical lateral as what it would be for the AP. You remember talking about that on the AP humerus, whatever position the humerus is in for the AP, it's got to be in the same position for the lateral. Kind of the same thing. But for the most part, if you're shooting a Denelius Miller, that's your surgical lateral, most common, term for it. If you're shooting surgical lateral, you got somebody with a broken hip. So whatever position the hip was in for the AP, that's what you're going to leave it in for the lateral. You're not going to internally rotate the toes for the AP, so you're not going to internally rotate the toes for the lateral. Okay, and that's what it should look like. It's going to seem to you like first time you shoot one of these, it's going to seem like the image receptor being placed all the way up here above the iliac crest for this hip down here is going to be way too high, right? You're not going to put the image receptor parallel to the leg. You're going to try to put the image receptor parallel to the head of the femur. Okay, it's going to feel like to you, it's going to seem like to you this is too high, but it's not. So put it above the iliac crest. Try to get it mashed into the patient just a little bit. Shoot from the opposite side, elevating that leg, externally rotating if you can. I'm going to try to externally rotate on one leg because I just can't do it. All right, so opposite direction, perpendicular to the image receptor. And that's what you should see. If you go below the iliac crest, what you're going to see is from about here down. You're not going to get the head of the femur. Okay? I folks are actually going to finish up. Okay, so we have a couple of other specialty views of the pelvis that we need to talk about. And I also need to talk about the um, the difference between what we do locally and what is in the textbook. Okay, so on the registry, of course, you're going to go with the textbook. So on page 412, Jude views. So if a patient has a broken hip or broken pelvis, rather, it's tough to see the fractures because none of the bones in the pelvis are going to be parallel to the image receptor. The iliac bones come off at an angle like this, right? The anterior pelvic bones are actually leaning backwards like so, okay? And they're also not only leaning backwards, but they're at an angle like this. So they got a double angle. This is where I really wish I had a skeleton with me. But the Jude views, according to the textbook, are specific for showing an AP and lateral of the acetabulum. So the acetabulum, again, is the socket portion of the ball and socket joint. So we're here, and the acetabulum is facing forward just a little bit. It's like this. So you can't really see it real well. So what we're going to do is we're going to do bilateral obliques. So it's facing kind of outward, but a little bit forward. So if I oblique the patient up, then what happens to the downside acetabulum? You can't see it really, but it's kind of a lateral projection, right? What about the upside? It opened up. You can see it straight on, right? So the Jude method is an AP and a lateral, unilateral acetabulum. Okay, so you're going to do two views. You're going to do, one that gives you the AP. So we're going to have the upside, we're going to see the AP, and then on the downside oblique, we're going to see the lateral. Okay, so that's a textbook Jude. All right. Now, again, your anterior pelvic bones are going to be kind of like this. They're going to be facing forward and at an angle. Okay, so kind of like this. Can you see the holes very good? Here, I'm going to do this more like that. Can you see the holes very good? So symphysis pubis right here. Can you see them very good? Yeah. Okay. What about now? One of them, right? All right. And then if I go the opposite direction, I can see the other one a little bit better, right? Now, what's happening there is that what we've got then is as I oblique the patient up, I can't make my hands do this. If I oblique the patient up, what I'm getting is an AP view of the upside anterior pelvic bones. But what's happening to the downside? It's lateral. It's lateral, right? So, what do we need to see to diagnose fractures? We can see a fracture line, but we can't see anterior to posterior displacement. So we shoot a second view that is 90 degrees from the first, right? So what we can see in the Jude view, even though the textbook says it's for the acetabulum, can we see AP and lateral of anterior pelvic bone fractures? The answer is yeah. In two views, we can see both of those. Also, though, what we've got are your iliac bones. Okay, so I can kind of demonstrate this. Your iliac bones are here. You got your sacrum here, right? You got your iliac bones here. As I oblique up, what happens to the upside iliac bone? Lateral, what happened to the downside? It's AP. So in two views, you can see an AP and a lateral of everything in the pelvis. Two obliques, you can see AP and lateral of everything in the pelvis. So as a result, our local doctors don't want us to do just one acetabulum. What they want us to do is bilateral obliques of the entire pelvis. If the patient's got, potentially broken anterior pelvic bones or fractures of the ilium, or what we refer to as vertical shear fractures, or separate, any kind of abnormality, traumatic abnormality of the pelvis. We're going to do two views. We're still going to call them Jude views. The textbook says Jude is just for the acetabulum. It's two obliques to show the acetabulum, AP, and lateral. Locally, I'm telling you, 14 by 17, full pelvis, two obliques. That's our Jude views because it shows you everything. So what if the patient's fractures are so unstable that you can't rotate the patient around? It happens. Pelvic fractures can be just nasty fractures. You got a lot of stuff going on there. Consider back to a pelvis. Consider everything that you've got going on in the pelvis. Now you got the urinary bladder. If it ruptures, I'm sure it's uncomfortable. Urine is sterile. So it's not really going to hurt them. They can put a suprapubic catheter into the patient and drain it out. Maybe it'll heal itself. Maybe they got to get in there and do some work, but it's really kind of going to be okay. But if we've got fractures of the anterior pelvic bones, we've got separation of the symphysis pubis, and especially if we've got a vertical shear fracture in our ilium, the vertical shear fractures, what do you have separating right about here to go all the way down to the feet? Major arteries, right? So you start ripping these things apart, and you got a problem. You got a potential problem, right? So the way those vertical shear fractures happen, and the way they present in a lot of cases is kind of like, have you ever seen when they've torn down a house or torn up some countertops or something like that, where there's some plywood and the plywood breaks and it rips? Okay, imagine that then. a lot of splinters, right? So you got these major arteries and major veins coming down through here, internal, external iliacs. You got some potential problems. So in some cases, you can have such an unstable pelvis that you don't want to rotate the patient around, but you still have to see where the fractures are, right? So let's now go back down. That's Judet views, original Judet views, and what we do. Okay, I thought I had some inlet and outlet views, but I don't. Okay, so look on page 414. If the patient is so unstable that they can't rotate for Judet views, then we still have some options. Again, your anterior pelvic bones are going to be at an angle, right? So we're going to have to angle the central ray to be perpendicular to the anatomy. It's going to be pretty steep. So notice though, because of the difference in the anatomy between men and women, if you look on page 414 and under central ray, direct the central ray 20 to 30 to 35 degrees cephalic for men, entering midline at a 0.2 inches inferior to the superior border of the symphysis pubis. Okay, so then you look down at women and it's direct 30 to 45 degrees cephalic, right? Well, at the same level as symphysis pubis, you've got your greater trochanter. So if you can find the greater trochanter, again, you don't have to palpate the symphysis pubis. Also, it's going to be about 4 inches below the ASIS as well. And then if you look on page 415, you see the result of that angulation. You kind of see a frontal view of those anterior pelvic bones. That obturator foramen is much more open, right? It's not closed, it's more open. So that is the Taylor method, and that's the outlet projection. If you flip over to page 416, you see the inlet method. And it's a Bridgham method. So in this case, what we're going to do is we're going to angle the central ray 40 degrees caudad to the level of ASIS. Okay. So you don't get AP and lateral, but you get a inferior superior that kind of straightens them out, and then you get a superior inferior that makes them, instead of like this, they're like that. So it's not a AP and lateral, but you're still pretty much 90 degrees from each other, so that you can see the fracture, and you can, like on the AP, and then you can see that will be the outlet view, and then you can see the displacement, anterior posterior displacement on the inlet view. Okay. Well, inlet and outlet views. Different angulations on the Taylor method, same angulation on the Bridgman method. Any questions?